Alright, so back at it. We stopped here, so let's just wrap up these last 25 questions for block 2, and we'll keep going after that tomorrow. So here we have number 26, a 32-year-old man who lives at sea level, travels to a mountainous region for a 2-month hiking vacation. So he's going into a higher altitude. On arrival at the mountainous area, he develops shortness of breath with exertion. At the end of his first 2 weeks of vacation, his exercise tolerance has increased. If this patient's bone marrow were examined at this time, it would most likely show increased numbers of which of the following cells. Now you look at all these acid choices and you're like, what the fuck is a normoblast? The most important thing to understand is that you can first cancel out acid choices and then come down to just picking a normoblast. For example, high altitude, he's been able to make more red blood cells now, and he's got better at managing this exercise tolerance. So it's definitely not because he made radipocytes, so you cancel that out. Definitely not because of siderophages, that's not related to this. Now megakaryocytes are for platelets, and platelets are not related to this either. Metamyelocytes are not related to this either, so you just pick normoblasts even if you don't really know what a normoblast is. So a normoblast, as it turns out, is an immature red blood cell containing hemoglobin and the pycnotic nucleus, and normally present in bone marrow, but appearing in the blood in many anemias. Right? This is something that I've never heard of. I didn't even know what a normoblast was before this myself, but I still wouldn't have picked anything else but the normoblast anyway, because the other acid choices just don't make any sense. Alright, so normoblast is an immature blood cell. And what happened to this patient is a very, very real thing. In fact, it's not something pathological at all. It can happen to anyone. He's pretty young. He's 32. So I just went in, I think August or something, right? I went to Colorado, which is a very high altitude state in America. And I was there to do the Tough Mudder competition, which is just an obstacle race, and I was doing the 10-mile run. So I got there, the race was supposed to, well, it's not a race, it's more of just like you run, you're not racing against anyone. So you do the 10 miles and that's it, you finish, and then they give you all kinds of stuff. So you got a Tough Mudder Classic headband, you get a bunch of other stuff so that you know that you've done it, and you walk out of that knowing and proud of yourself that you did it. So I got to Colorado on a Thursday, and I was running around with some dogs because I was living with a friend and he had dogs. And I would run out of air like immediately. And I've been training like a month and a half before that for running. And I was like, what the heck is happening? I would go up a couple of stairs and I would run out of breath. The amount of air and the dryness in the air there was crazy. It was still pretty hot here in New York, but it was much more chilly over there because the air was so dry. And on the day of the race, I could barely run. Like, majority of it was just walking, and I did the whole 10 miles, but I was so out of air. Like, I had to take deep breaths to maintain the same amount of air that I would on, like, an average day just sitting there. So this is a very real thing that happens, and had I been training in Colorado the whole time, I would have been much more ready for it, because I would make more red blood cells to manage, working with that hypoxia, I guess. 27, a 40-year-old man with terminal small cell carcinoma of the lung becomes anorectic and lethargic. Fluid restriction is initiated because of a serum sodium concentration of 120 milliequivalents per liter, but there is no clinical improvement after 3 days. Which of the following is the next most appropriate therapy? So you're supposed to figure out what's wrong with this guy. First of all, they tell you he has small cell carcinoma, which is very specific. They didn't say he has squamous cell carcinoma. Right? Squamous cell carcinoma is the one that's related to PTH-related peptides. Small cell carcinoma has many different issues to it. He is presenting with a very low sodium. Right? Fluid restriction is initiated because of a serum sodium concentration of 120. But there is no clinical improvement after 3 days. So because they're talking about this fluid restriction stuff, you should understand this is probably a case scenario of SIADH. So page 372 kind of talks to you more about that stuff. So what happened here? You're going to have, an SIADH, you're making too much ADH, antidiuretic hormone. So your urine osmolality will be much higher than your serum osmolality, which means that the urine concentration of things is very high because there's no water in it. And your serum concentration of things is low because your serum has a lot of water in it, right? And that's what this Darrow-Unit diagram is kind of showing you, right? Excessive free water retention. You have euvolemic hyponatremia with continued urinary sodium excretion. The euvolemia is due to something that's also related to another topic, the aldosterone escape mechanism. It's related to the ANP and BNP, right? These guys are going to cause increased urinary sodium secretion, but you're going to have normalized extracellular fluid volume, which is why you have euvolemic hyponatremia. So this is only, tested in two different ways. You're either going to have a patient who actually has like a cancer, right? So ectopic ADH, which is our patient right now, or you're going to have someone who has one of these other issues, and these are a little rarer. As you can see, cyclophosphamide is actually one of our answer choices, but cyclophosphamide would be something else that would cause SIADH, not fix it. SIADH can be fixed with demeclocycline, which was actually originally made to be used as a cyclin, right? But now it's not used for that anymore. They figured out that it actually helps with the ADH stuff by acting as an ADH antagonist. All right. So fluid restriction is the first line therapy, and then ADH antagonists like conivaptan, right? Vaptan means vasopressin antagonist, right? Tolvaptan and demeclocycline. Fluid restriction severely decreases the serum osmolality, but it does not change the urine osmolality in central or nephrogenic DI. Water restriction causes euvolemic hyponatremia in SIADH. Alright, so that's it. The other medications don't even make any sense. The only thing you could possibly pick here was just demeclocycline. 28. A 32-year-old man has a diastolic blood pressure that consistently ranges between 100 and 110. He is otherwise healthy and is not taking any medications. Serum concentrations of potassium, glucose, creatinine, cholesterol, and urate are all normal. Urine contains only trace amounts of protein and no albumin. He is unlikely to develop peripheral tissue edema because of regulatory adjustments in which of the following? Okay, so they're basically asking you what's going to cause edema, right? This question got a lot of people confused, and many of the people also chose lymphatic flow, which is choice B. This patient has diastolic hypertension, right? Because they tell you his diastolic blood pressure is over 100. That is related to filling pressures of the heart. But the systolic blood pressure is presumably normal, right? Because they don't mention anything about it. Systolic blood pressure is determined by cardiac output, and diastolic blood pressure is determined by arterioles, which are before the capillary. Hence, the answer is just precapillary resistance. This was more of a question on testing you on the concepts of things. There was no real way to actually, per se, know the answer or something like that. So, when you're talking about any question scenario where you're talking about diastolic blood pressure, that's going to be measured by arterioles, and arterioles are precapillary. So you're looking at precapillary resistance. This is a very weird way to ask a question on this topic, and I can see why a lot of people would get this wrong. But at the end of the day, you should have actually came down to D or E, postcapillary or precapillary resistance. One of the two definitely has to be involved in this diastolic hypertension, and it's actually the precapillary stuff. All right. There's nowhere else to really reach out to for an explanation of this question, and I really don't know what else I could possibly say. But if you ever get a question about diastolic heart failure or diastolic hypertension, consider precapillary resistance as one of the issues. It's definitely not the systemic venous pressure that would be related to systolic hypertension. Lymphatic flow, again, because they mentioned, he is unlikely to develop peripheral tissue edema because of regulatory adjustments in which of the following. Since he's unlikely to develop the peripheral tissue edema, it's not going to be because of lymphatic flow. If lymphatic flow was involved, he would have tissue edema, right? So you can't really adjust anything there. Capillary membrane permeability was another trick answer choice that's not really related to this topic. You can't really per se alter capillary membrane permeability. Capillaries are one cell thick and their permeability is fixed, so you can't change it. Right? Plasma oncotic pressure was also irrelevant for this patient's scenario because he doesn't have renal failure. If he had renal failure, then his creatinine would be high, other things would possibly be low, and in that case he could have increased oncotic pressure. Right? So the precapillary resistance is going to be altered, which is at arterioles, and by altering that, you'll prevent having tissue edema in this patient. That's basically what this question was about. Very weird question. I can imagine a lot of people getting this wrong and being confused about it. 29. A 65-year-old man develops progressive ataxia with gait unsteadiness. There is an intention tremor on the right side. The most likely cause is damage to which of the following areas of the brain? So we've been doing neurology this whole time, right? He has gait unsteadiness and ataxia. And an intention tremor on the right side. So that's why they put all these answer choices that are on the left. But remember, this person with the ataxia, it has to be on the same side stuff, right? Gait unsteadiness and ataxia are all related to cerebellar lesions. So you're really down to A or E. The others don't really make sense. Frontal lobe would be acting weird if you get an injury there. Pyramidal tract would mess up your corticospinal tract, which is a descending motor tract. Ventrolateral nucleus of the thalamus. Ventrolateral is, I guess, like the VPL stuff, so that would be more of a sensory loss. And again, the right pyramidal tract is also corticospinal. So we're not talking about corticospinal, we're talking about cerebellar things related to ataxia. And cerebellar lesions are always ipsilateral. You have to remember that. When we talked about the cerebellum, we discussed the fact that everything is either ipsilateral or bilateral. So they tell you here, lateral lesions affect voluntary movement of extremities. When injured, propensity to fall toward the same side, ipsilateral. Medial lesions in the green area here or the pink areas here, those lesions are going to cause truncal ataxia, which is bilateral, right? Your whole trunk is going to be ataxic, and generally results in bilateral motor deficits affecting axial and proximal limb musculature. Right, so this guy's issue had to be on the same side, so you would pick the same side. So he had, he had right side intention tremors, so right cerebellar hemisphere. That's it. Number 30 was, I think, Alzheimer's? Yeah, in 85. So 85 is really, really old, right? She's way past 65. 85-year-old woman is brought to the physician by her daughter because of a 3-year history of progressive forgetfulness. Mental status exam shows moderate difficulty learning and recalling new verbal and nonverbal material. She also has mild difficulty with naming and calculations. Which of the following is the most appropriate pharmacotherapy to improve her symptoms? You look at all the medications. Coenzyme Q is something we can all take. It's kind of like a vitamin. We can all eat coenzyme Q every day, and it's mostly for cardiac and vascular health. Riluzole is for ALS, so that's not going to be relevant, right? Remember riluzole for Lou Gehrig. Selegiline is a MAO-B inhibitor, and zinc is another vitamin that anyone can take. We're thinking of a medication for Alzheimer's, and that's going to be donepezil. Donepezil, rivastigmine, and galantamine are treatments for Alzheimer's disease. A study is planned to assess differences in hypertension control between patients in the USA and those in Western Europe. The study population includes 21,053 patients with hypertension receiving care from 291 cardiologists and 1,284 primary care physicians in 5 Western European countries and the USA. So they're throwing in a bunch of really weird numbers, right? None of these are solid numbers. The main outcome measure is hypertension control, defined as the most recent blood pressure reading less than 140/90. Which of the following best describes this study design? So they're looking at a bunch of people right now. So that's just cross-sectional, right? This is an observational study. This is looking at patients who are receiving care. So it's happening right now on the timeline. They're not looking at people who already received care in the past, nor are they looking at people who are about to receive care and then later check if any of them improved. This is cross-sectional, right? Pretty straightforward. Really no room for mistakes here. This is not a clinical trial. This is not a case control. It is definitely not a cohort where you would be looking into the future, right? Prospective cohort. So that was it for that. 32. A 35-year-old man comes to the physician because of a 4-month history of persistent cough and intermittent nasal discharge. He feels well most of the day, but after going to sleep, he will often awaken with shortness of breath, wheezing, dry cough, and chest tightness. Okay. So nasal discharge, persistent cough, and then this asthma type stuff. Vital signs are normal. Physical exam shows no abnormalities. The most appropriate drug for this patient blocks the receptors for an endogenous substance that is a metabolite of which of the following? So if you look at all your answer choices, histamine metabolites don't make sense, prostacyclin metabolites don't make sense, THF metabolites and tryptophan metabolites, for the most part those guys don't even have metabolites, right? So the only answers you could pick is arachidonic acid. This patient probably has asthma, and asthma drugs are, either you have your leukotriene inhibitors, which you could take, montelukast or zafirlukast. Those medications would work fine for this patient. Okay, so he might have been given an inhaled corticosteroid or an anti-leukotriene, both of which inhibit some product of arachidonate. Okay, number 33. What's this? Female neonate. Okay, this was a pretty weird question. A female neonate is delivered at 38 weeks gestation by cesarean section. Physical exam shows macrocephaly and shortening of the proximal segments of all limbs. A diagnosis of achondroplasia is made. DNA sequencing shows a G to A mutation in the fibroblast growth factor 3, FGF3 receptor gene on chromosome 4. The biosynthesis of this protein requires functional signal recognition particle receptor. This receptor is most likely found in which of the following cellular location? So signal recognition particle, the SRP stuff. This is discussed actually in biochemistry very accurately. They even tell you what happens if it stops working. Right, so when you're looking at your cell trafficking, here we're looking at the Golgi apparatus and the left endoplasmic reticulum. Right, your signal recognition particle, abundant cytosolic ribonucleic protein that traffics polypeptide ribosome complex from the cytosol to the RER. Absent or dysfunctional SRP leads to an accumulation of protein in the cytosol. Right, that's all your signal recognition particle is for. So in this question, when they ask you, biosynthesis requires a functional SRP receptor. This receptor is going to be where? Well, the receptor must be on the RER because that's where the signal recognition particles sends things to. Right, so it's being received at the RER. A topic that isn't, I guess they didn't mention it in first aid, but you would have to understand that, and understand that, the mRNA ribosome, secretory granules, and okay, I could see how someone could pick one of the Golgi things because it is on this page, but the cis and trans Golgi stuff are only for taking things away from the RER towards outside, or from here back to the RER, right? So you can see. Alright, this is back to square one. So COP1 is the one that's bringing stuff back to your RER. And 2 steps ahead is your COP2, taking things away. Right, and then all the way over here, you have your clathrin. Clathrin is the worker. Right, trans Golgi to outside. So you can send it to wherever the heck it needs to go. But the signal recognition particle, which is not in this image, its job is to bring things from the cytosol, outside, not the Golgi, from anywhere out here in the cytosol to the RER. Alright, and that's a different topic, and that's why you would pick RER. Cis Golgi, trans Golgi, those are guys that are going to be more so responsible for your actual Golgi complex and sending proteins from the cell out of the cell. 34, they gave you this ECG strip, and they tell you electrophysiology of the heart is studied in an anesthetized experimental animal. Initially, an ECG shows no abnormalities. Which of the following procedures is most likely to produce the ECG abnormality shown? Okay, so what are we seeing here? So the QRS complex, right, you have your QRS. The QRSs they're not that bad. The QRSs are fine, but the P's are hard to see. Right? We can't really, this is one P wave right here. Then you have a QRS. Then this is supposed to be a P, but then there's no QRS. Then this is a P. Then there's a QRS. The whole P wave stuff is everywhere. Right? The QRSs are working fine, but the P waves are kind of messed up. So your P wave is kind of more so related to your atrioventricular node. So over here I wrote the distance between QRS complexes is continuously about 6 boxes, so the rate is unaffected. This is a 3rd degree block where the atria and ventricles are beating independently of each other, right? And the RR is equivalent all along. The RR is the distance between the peaks up here. The second QRS complex is super narrow, this one right here, very, very narrow. That also tells you a lot. And others are also narrow, which means they're depolarizing thanks to the bundle of His. Always remember that. If you see a QRS complex that looks like this, super, super, super skinny, that means that the ventricular depolarization is thanks to the bundle of His. So when we go to page 311, here we can kind of see, look at this QRS complex, right? That's not so skinny. These are QRS complexes that are normal QRS complexes that are actually happening because of the SA node, right? And then when you come into AV block, look at what happens. You see how the QRS complexes look super skinny now? Right? And especially where you get to a third degree AV block, look at how skinny this one is. It's so skinny that it actually kind of looks like something like this happened. It's so skinny that it looks like something like this is happening. Okay? So really, really important to understand that concept. The difference that you can see very evidently between here, right? You can see there's a bit of a space between. But here you can't. It just goes straight up and comes straight back down in all of these guys. So that difference is always a good way to catch an AV block, right? And that's our question. It's an AV block, so it's going to be ablation of the atrioventricular node. That's it, right? Anytime you see that. Ablation of the bundle branch fibers would not cause this. If you do something to the bundle branches, then you're kind of going to have to first figure out, is the left bundle branch or the right bundle branch, which one are you actually doing it to, and your ventricles would not be contracting at this good pace like that. Ablation of the SA node, again, that would affect your QRS, but your P's would be okay. Remember, in any of these choices, in choice B, choice C, destruction of part of the left ventricle, destruction of part of the right atrium, all of these would not mess up your P waves. Your P waves will be happening correctly, right? But here, your P waves are very, very messed up. So as soon as you find that one thing that is very prominently wrong in the ECG, check for which answer choice would affect that one thing. And the other answer choices should not have a major effect on that one thing. This was a really easy question on finasteride. So a 40-year-old man comes to a physician for routine health maintenance exam. He has an active lifestyle that includes swimming and cycling. Physical exam shows no abnormalities. He's concerned that his male pattern baldness is affecting both his professional image and his ability to attract sexual partners. Which of the following treatments is the most appropriate recommendation for this patient? None of these other medications can actually help with baldness, and methyl testosterone would probably mess it up more. Right? Finasteride is actually a medication for BPH, but it is also sold under another trade name, and it's skipping my mind. But so finasteride itself is usually a 5 milligram tablet, but if you take it as a 1 milligram thing, which is really hard to get, if you take it as a 1 milligram thing, then it helps with the male pattern baldness. The 5 milligram tablet is actually for the BPH stuff, and that you can get covered under your health insurance. But if you want the finasteride as, Propecia, it's called Propecia. Propecia is the weaker version of finasteride. It's a lower dosage, and Propecia is used for the male pattern baldness, but you have to pay for it. So a lot of times what doctors will do is they'll still prescribe you finasteride, and in your system they'll put that you have BPH, and what you have to do is you have to buy a pill cutter and cut the finasteride into 4 pieces and eat it like that. Right? So that's how you kind of not have to pay for finasteride for male pattern baldness. But definitely a medication that gets tested for this topic all the time. This is this is NBME 23, and this is still popping up. So it's a very common thing that they definitely want you to know about. 36. A 65-year-old man is brought to the emergency department because of intermittent substernal chest discomfort over the past 24 hours. Which of the following eicosanoids is most likely contributing to his symptoms? So what's causing his intermittent substernal chest discomfort? Well, if you look at all of these, you can definitely cancel out leukotriene B4, right? Because B4 is for neutrophilic chemotaxis. Leukotriene E, C, and D4 are actually for asthma stuff, and this is not the substernal chest discomfort they're talking about here. I have no idea what F4 is, but we'll cancel that out too. Or maybe if everything else doesn't make sense, we'll pick it. However, we're talking about eicosanoids, so you should really not be picking a leukotriene anyway. Prostaglandin E2 is more so for just keeping your the heart thing open, so this isn't related to that either. F2 alpha, again, not so much related to that. Thromboxane is related to vascular tone, and this could be substernal chest pain for what might be leading to something like an MI. Alright, so thromboxane E2 increases platelet aggregation and vascular tone, the vascular tone being the bigger issue, and his acute chest pain is probably related to increased vascular tone, hypertension. Alright, the other ones don't make any sense, they just don't. They're not related to chest discomfort at all. So if you go to page 528, you can look at your beautiful arachidonic acid pathway again. Right, so the F2 alpha, always remember this is the uterine tone, right? PGE, again, uterine tone and vascular tone, but more so, we've been looking at these medications ever since cardiovascular, and these prostaglandins don't really have a play in chest discomfort per se. And if anything, PGE1 would have made the vascular tone lower, which would help with this chest discomfort. All the leukotrienes, except for B4, are for bronchial tone, increasing it. B4 is for neutrophil chemotaxis because neutrophils come before everybody else. Alright? So, thromboxane A2, that's it. You would just pick that and move on with life. A 17-year-old girl with type 1 diabetes comes to the physician for a follow-up exam. She has had multiple admissions to the hospital during the past 5 months for diabetic ketoacidosis. So recurrent diabetic ketoacidosis, okay? She appears well. Physical exam shows no abnormalities. Lab studies show a hemoglobin A1C of 11.5%, which is really high. She tells the physician that she does not take her insulin regularly because she either forgets or is too busy. Which of the following is the most appropriate initial step by the physician? And they really want you to understand this. They really want you to understand this. The most appropriate initial step is to always acknowledge what the patient is saying. Your patient just told you, yo, I keep forgetting to take my insulin because I'm too busy and I just don't want to do it. First thing you have to say is you acknowledge the patient's reasons for missing insulin injections. Yeah, I totally get that. A lot of people miss their insulin injections all the time. Then you can go ahead and educate the patient about long-term complications of not treating diabetes and how diabetic ketoacidosis can actually be fatal to her, right? That would not be the initial thing. So this student chose C, which, you know, definitely, of course, we're all dying to do that for this patient, but that's kind of like, you know, when you get your teenager that's not listening to you and you want to scold them and beat them or whatever, or lecture them, right? You can't do that. You can't do that. That's not how you could treat a patient, and you shouldn't do that with your kids either. You just acknowledge the difficulty and then educate. And the other answer choices don't make sense. You're not going to refer a psychologist. You're not going to tell, you know, the patient's parents anything about this stuff. It has nothing to do with the parents. And again, parents, right? So nothing to do with parents. Just cancel out those answer choices immediately. You're between A and C, and understand that A is a lot more sensitive. A lot more sensitive. C is rude, right? Understand the compassion. Understand that your patient, you know, you got to act like your patient is the most sensitive person on earth, and you can't say something that might hurt them. 38 or 65-year-old man comes to the physician because of a 1-year history of erectile dysfunction. He has a 20-year history of type 2 diabetes and is currently taking insulin. Physical exam shows and lab studies show no abnormalities. It is most appropriate for the physician to prescribe an agent or prescribe a drug that increases the actions of cyclic GMP in which of the following cell types in the penis. So cyclic GMP is going to cause vasodilation of arteries, and arteries are smooth muscle. Alright. Now, if you knew that and you came down to answer choices D and E, then you have to remember that the deep artery is the one that you have to pick, not the deep dorsal vein, right? It's not the vein. You're sending blood into the penis, you're not making the penis erect by drawing blood back out of it, right? The vein would be the wrong answer, right? There's no reason for you to pick a vein. That's not what's happening here. You're sending it into the deep artery. So if we go to page 716, there's a picture there, right here. Okay, so you can tell these are all arteries, right? Everything comes from your internal pubic artery, right? It goes under and on top, right? And the ones that are going into the corpus cavernosum, those are the arteries we're trying to fill up with blood to get the erection to go. All right, and that is your deep artery. Okay, always remember that deep artery is the artery to the corpus cavernosum. This is a very common test topic. They keep asking this on NBME. In NBME 20, we had an image. It was a big image, like, you know, like they had a big picture, and they said they took a cross section of the penis, and it had the two corpus cavernosums, and there's something tiny down here, and they labeled it like 1, 2, 3, 4, something like that. And they were like, where would, you know, this medication, Viagra, where would you be sending more blood? You would be sending more blood to 1, right? Because 1 is the deep artery, and that's your corpus cavernosum. That's where you're sending blood. So they love testing this topic, so make sure you don't forget that, because it's pretty straightforward, pretty easy, not really a difficult question. 39. A 35-year-old man who is a veterinarian in a rural area comes to the physician because of headache, cough, fatigue, and myalgia 2 weeks after assisting in the delivery of a lamb. Temperature is 102 F, leukocyte count is 12,000, hepatic transaminase activity is increased, so his liver enzymes are high. An X-ray of the chest shows the presence of patchy infiltrate. Gram stain of sputum and culture of blood and sputum are negative for pathogens. After 2 days of doxycycline therapy, his symptoms are alleviated. Which of the following is the most likely causal organism? Well, they just told you that he was working with the lamb, so just pick whichever one of these is a lamb. Whichever one of these is related to a lamb. And Coxiella, if you did sketchy micro, Coxiella should remind you of the ram named Curly Q, and it does cause the patchy infiltrate. So let's take a look at it. Page 151. Sketchy micro has a farmer in a barn with this guy right here. Right, and this thing on the cow is supposed to remind you that it affects the liver. This is how the patient is presenting. Right, myalgia, he's got the headache, sweating, flu-like symptoms basically, and the patchy fog around him is to remind you of the air infiltrates. And it's actually, you can see the nuts here because it's got the shell, and it's related to the feces as well. Right, it's really important to make sure you remember that. Right, spores. That's what the nuts always remind you of. Coxiella makes spore-like structures that end up in dirt, and then you just end up inhaling it, and you can get symptoms similar to pneumonia. You also get hepatitis, and chronic Q fever can lead to endocarditis. Treatment is with doxycycline or hydroxychloroquine. So, not that bad at all. All right, not that bad at all. You just have to remember that, though. If you didn't remember that, you know, then chlamydia you always think of with parrots. Bacillus anthracis is also, that's just a bacilli, so it's not really. Bacillus anthracis you would think of with wool from, you know, the sheep. Francisella is a rabbit, so that's another one. And rickettsii would have rashes on the palms and soles, so that didn't happen here either. Alright, it's really important to remember that. Sketchy Micro does a great job by, you know, incorporating all the correct pets as you need to know them. This is Francisella with the rabbits. Alright, this is Bartonella with Bart, your leopard print tiger, causing different things if you're immunocompetent versus immunocompromised. Right. Really important to know that when I did the Sketchy Micro stuff with my microbiology lectures, I included everything, and I talked about the high yield guys that I've highlighted here because they show up a lot. You really don't want to get that one question wrong about that one bug because it's just a memorization thing. 40, a 35-year-old woman, G2P1, undergoes vaginal delivery at term. Physical exam shows crowning of the newborn's head and perineal blanching. A median episiotomy is done to hasten delivery. And this is a very high yield topic. You've probably already seen a question in UWorld about a median or medial episiotomy. So that's where you kind of cut downwards to make the opening bigger. Median episiotomy is done to hasten delivery. During this procedure, an incision is made posteriorly from the posterior vaginal commissure. Which of the following muscles is at greatest risk? You're going to mess up your perineal body. You're going to mess up the perineal body. That was what UWorld taught you. And that after that comes the external anal sphincter. So that's it. You need to remember this image. I'm going to show it to you right now. Excuse me. And as long as you remember these images, you're going to be able to solve these questions just fine. First image is this one. This is what's happening in our question. So in our question, what they're doing is they need to make this opening bigger, right, to get the baby out. So they're going to make a cut down here, like that, right? So when they make that cut, move this out of the way. So when they make that cut like that with the red line that I'm showing you, that is a medial episiotomy. So first thing you cut is the perineal body, but if you go too far, then you can see right after the perineal body is this round muscle, which is your anal sphincter, more notably the external anal sphincter. So if you injure the external anal sphincter, you can get the mother to end up pooping during delivery, which is a very common thing. The other reason the mother can end up passing feces during delivery is because of pudendal nerve involvement. So you need to remember, this is the same image again, but now you're seeing the pudendal nerve and how it's all over here. Okay, this is not the same exact image though, because now we're looking at the male anatomy, right? And this is usually, the pudendal nerve is usually a question about the male. So you can see there's the scrotum up here, you have your bulbo cavernous body over here and all that stuff. So same angle, but now we're looking at a male. But the pudendal nerve is also there in the female as well, and oftentimes you have to do a pudendal block in the female during delivery as well. Okay, and you can find that, I think in musculoskeletal I have a picture of that I've shown before. But really, these are things you should be looking at pretty often. You see, again, you can see the pudendal nerve here. Right, so the pudendal nerve is really significant when it comes to both genders actually, but mostly the male. And for pelvic floor anatomy, this question keeps popping up everywhere. It's a very common question. So perineal body and the external anal sphincter. Always remember those things for medial episiotomies during delivery. 41. A 6-month-old infant is brought to the physician because of a 2-month history of failure to thrive and intractable diarrhea that is worse after he feeds. Physical exam shows eczematous dermatitis and mild lymphadenopathy. His heel stick blood glucose concentration is super high. Genetic testing shows a mutation in the gene encoding for the transcriptional protein FOXP3. You might not even remember what FOXP3 is. The most likely cause of this patient's condition is a decrease in which of the following T lymphocyte populations. Now, you should feel fairly confident when you think about Th1, Th2, natural killer, and CD8 positive T lymphocytes. But when it comes to regulatory T lymphocytes, there's probably so much you don't know, so you just pick that answer choice and you move on. Because you know for goddamn sure FOXP3 has nothing to do with all those other answer choices, and that's actually how this student got it right too. So he told me when I got to this question, I said, did you remember FOXP3? He said, nah, I just know it has nothing to do with the other 4. So he picked C and that was it. This is actually discussed in immunology too though. It's related with some autoimmune stuff, right? So right here, if you look at your regulatory T cells, IPEX is immune dysregulation, polyendocrinopathy, hence the diabetes the baby has, enteropathy, and X-linked, which is why I believe it is a male baby, right? 6-month-old male infant. It's a genetic deficiency of FOXP3, which leads to autoimmunity, characterized by enteropathy, endocrinopathy, nail dystrophy, and many more things associated with diabetes in male infants. Okay, so that was a question from NBME 23 right here, directly about FOXP3 and IPEX. And IPEX, that's related to regulatory T lymphocytes. When we look at T regulatory right here, IPEX. Okay, so that's it. One little topic, one little simple easy topic. Definitely worth getting correct because you're probably not going to get a question on it anyway, but if you do, it's a very specific question. Like you see how this question directly points at the answer. It's not like something where you have to kind of think about it. 42, a 7-year-old boy is brought to the physician by his mother because of a 2-day history of an itchy red rash on his right arm and trunk after a hike in the woods. His mother says that the rash began on his arm one day after the trip, but it has now spread to his trunk. Okay, so it started from the outside and now started from the arm, went to the trunk. Physical exam shows 2 centimeter patches of raised red elongated blisters that ooze clear fluid on the upper extremities and trunk. The blisters are in a linear distribution with patches of erythema. Which of the following best describes the mechanism of this patient's reaction? Okay, so this is another immunology question. First of all, notice how the rash started one day after the trip, right? So that's kind of making you remember the fact that this must be a type 4 hypersensitivity. Right, this is not related to some kind of actual infection though, right? Because they didn't mention a fever or erythema, anything like that. So now you look at your answer choices. Activation of mast cells by IgE does not take that long. It would have occurred the same day. Deposition of antigen-antibody complexes. Antigen-antibody complex, you're thinking type 2 hypersensitivity. Late phase reaction of a type 1 hypersensitivity is just a confusing way to make you think of type 4. Right, but it's not. Late phase type 1 is just the late phase of type 1. And synthesis of high affinity IgG by B lymphocytes would be something you would do for bacteria. There's no bacteria here. This is just a release of interferon gamma, but Th1 cells, T cells. T cells are what are involved in type 4 hypersensitivity. So if we go to page 113, this guy just went hiking and he probably cut himself with some oak or something. So type 4 hypersensitivity is just T cells. That's all you really needed to know. Okay, and this is because it can be from poison ivy, nickel allergy, graft versus host disease, anything. Response does not involve any antibodies. Right, your PPD test for TB infection and the Candida skin test also use the same type 4 hypersensitivity stuff. Right, so that's all you have to think of here. And don't let the interferon gamma stuff throw you off. Just understand that it's going to be T cells. And that's it for that question. 43, a 40-year-old man. Okay, this is from neurology. Another thing, I know that this student got almost all neurology questions wrong because he had not yet studied or revised at least the neurology topic. So a 40-year-old man comes to the physician because of a 3-month history of episodes of an abnormal tingling or pins and needles sensation that starts in his left hand and then spreads to his left arm and face. The episodes last approximately 1 minute. Physical and neurologic exam show no abnormalities. The most likely cause of these symptoms is a lesion in which of the following gyri? And you look at all your gyri and you know there's involvement of either the post or precentral, right? Those two guys are really, really significant. We've been looking at the motor cortex for a long time, and this is going to be the post-central one, which is your somatosensory one. Right? The precentral one is the one that you the one you move with, the motor one. So if we go to 543, right, so this is what we're talking about. The primary motor one is precentral, and then here you have post-central sulcus one. The post one is somatosensory. Right? And this guy has sensation issues, right? He's sensing things. He doesn't have motor difficulty, he has sensory difficulty. Temporal and occipitotemporal are unrelated, and your cingulate gyrus, let me see, do they have it in this picture? They didn't label the cingulate gyrus here, but we have talked about it in one of our videos. But let me just find a few online and hold on a second. Cingulate gyrus, what was that significant for? Oh yeah, right, that's why. Because it's not an actual gyrus, right? This is the cingulate gyrus. We've looked at that before. That's one of the guys in your the limbic system. That was your cingulate gyrus, and this is not that. The limbic system, remember, is involved in the 5 F's of fleeing and all of that stuff, feeding, fear. So that was just a trick answer, but it's not an actual gyri or sulci. It's a thing inside your brain. Okay, so that one didn't make any sense. Post-central was the answer for this one. 44, a 2-year-old boy is brought to the emergency department because of severe abdominal pain and vomiting for 3 hours. He also has had episodes of abdominal pain during the past year. Physical exam shows yellowish white papules on the back, generalized abdominal tenderness, and hepatosplenomegaly. Okay, 2 years old. Serum studies show an increased amylase activity, so that sounds like pancreatitis. Increased concentrations of cholesterol and triglyceride. The patient most likely has which deficiency? So this is one of your dyslipidemias, very evidently, especially from the last part. And because they're telling you he has the pancreatitis and an elevation in triglyceride, it has to be, the only ones that do that, the pancreatitis stuff, are type 1 and type 4. Type 1, let's go back and look at it. What page was it? 94. We've looked at this page so many times as we've been revising questions, and there's an easy way to memorize it. That's the mnemonic stuff I put at the bottom right here. Right, so type 1 is always LL or C2. It's either lipoprotein lipase or its cofactor, ApoC2. Type 4 has 4 letters, VLDL. You're making too much VLDL. It's not a problem with any kind of receptor or something. You just make too much VLDL. These patients have crazy high triglyceride levels, and that leads to pancreatitis, and they're also going to become insulin resistant because of all the excess adipose. But this patient, our patient in our question, has type 1, and they didn't mention the creamy layer in the supernatant. That's usually the giveaway for type 1, but they didn't mention it. Type 2 and 3 are the ones that have too much LDL, which leads to accelerated atherosclerosis. Type 2 has ApoB100, and type 3 has the 3 to remind you of ApoE, right? 3, the letter E should remind you of ApoE. That's it, right? If we look at our question, though, for our patient right here, this guy has vomiting, abdominal pain, yellow-white papules are they're talking about the xanthomas like this, eruptive xanthomas. Okay, so this image right here, that's what they're pointing out right there. And everything else just falls into place. Pancreatitis, high triglyceride, lipoprotein lipase. Okay, the other answer choice that would have also fit though would if they said high VLDL production. 45 was also easy. Nice question about a myxoma. So 43-year-old woman comes to the physician because she has fainted on 3 separate occasions during the past 5 months. After the most recent episode 2 weeks ago, she noticed weakness of her face and right arm, which resolved over the next 2 days. Her vital signs are within normal limits. Cardiac exam shows a mild grade 2 out of 6 diastolic murmur over the apex that becomes more pronounced when the patient rises from a prone position. So we're talking about some kind of issue with a 43-year-old woman, and a diastolic murmur is D-arm, so aortic regurgitation, or mitral stenosis. Which of the following is the most likely cause of her syncope? So you start looking at all your answer choices, and now you start figuring out the fact that they're probably talking about some kind of tumor. And she's got many issues. She has the weakness of her face, her right arm, right? She's starting to show some kind of systemic effects. And remember that her left atrial myxoma, it makes interleukins. So if we go back to that, 337, you have to remember that interleukin 6 production is related to myxomas, right? And that interleukin 6 production is what causes the weight loss and fever and many other systemic symptoms, right? You're going to have a diastolic murmur, heard best at the apex. All of that is fitting her scenario, right? Interleukin 6 production, really, really important to remember that one part. So that was the only answer you would pick. The others don't make any sense for her diastolic murmur and her systemic symptoms. Last few questions. 46. A 12-year-old girl is admitted to the hospital for treatment following a generalized tonic-clonic seizure. She has mild mental retardation and scoliosis. Okay. She underwent surgical repair for partial dislocation of the lenses in both eyes 3 years ago. So they're really giving away many really, really critical symptoms here. Plasma cystathionine concentration is low. CT scan of the head shows a small infarction in the right cerebral hemisphere. Which of the following serum amino acid concentrations is most likely high in this patient? So the clinical picture they painted here kind of has that overlap with Marfan, but it's not Marfan. It's more than that. This is Homocystinuria. Remember that in Marfans, the lenses fan outwards, but in Homocystinuria, the lenses tend to fall downwards. Okay, so instead of the lens dislocating upwards, the lens dislocates downwards. They didn't say that here. So they didn't mention that the lens dislocated down or up or anything like that, but everything else falling together with her seizures, lens dislocation, scoliosis, mental retardation, and cystathionine, they really gave away the homocystinuria. But homocystinuria is a really complicated disease because it has many different presentations. Many different things can cause it. Right? So you see how there's 1, 2, 3, 4 different things that can cause it. But you always have to remember that the issue here was you could not go in this direction towards the right. So you couldn't go in this direction. Right? They're unable to go in this direction. So oftentimes what ends up happening is you end up just going in this direction. Okay, because cystathionine synthase is not working. So you take all your homocysteine and you send it to methionine, and you end up making a lot of methionine, which isn't really bad for the patient per se, but that's what the question is testing you on. Right? And then this is what I was talking about with the lenses. Right? So you see in Marfan's, the lens is upwards, whereas in homocystinuria, it's not going to go upwards. It's either going to go like medially or downwards. Okay, tiny little thing, but definitely worth knowing. So they tell you here, downward and inward lens subluxation. So that was just homocystinuria. 47. A 48-year-old man has complete loss of hearing in his right ear. Which of the following labeled cranial nerves on the photograph of the ventral surface of the brainstem is most likely to be damaged? So they labeled everything, pretty much, right? And this is a really bad picture to pick off of, but it was C for this one. We're talking about a guy who probably has a schwannoma of your cranial nerve 8, and that's C. How you would get this correct is, really dependent on whether or not you can make the picture bigger, because you do have to study that stuff, and we've looked at it in our neuro lectures recently as well to figure out how you're supposed to get it correctly. But it takes time. It definitely takes time. It's part of the neuroanatomy stuff from the brainstem. And let me see. Yeah, right here. Something's happening at home, but I can't go right now. Yeah, so we're talking about this one, vestibulocochlear nerve, right? Number 8. That's the one we had to identify. But the picture they gave you wasn't a drawing. They gave you a gross image like that. That's a little harder to work with. And when you look at it, compare. Let me put this there too. When you compare the images like that, it's weird. It doesn't exactly help. I mean, you can definitely knock out A and F. You can knock out G, H, and D and E, but then B, C, and J are a little hard to work off of, and it's kind of hard to even point out the exact nerves like the way we can over here, right? But we're concerned with our cranial nerve 8, which is 5, 7, 8 right here, this one, right? And that was C. Okay, so I don't like the question because I don't like the picture, but if you are given a good picture, you should be able to pick it out. Next one, 48. A 60-year-old man comes to the physician because of a 1-month history of headache, dizziness. Blood pressure is 160/85. Physical exam shows moderate splenomegaly. So very, very high blood pressure and splenomegaly. 60-year-old man. They give you the lab studies. His hemoglobin is super high, right? Because it's like, it shouldn't be more than like 17, maybe even 16. MCV is very low though. Mean corpuscular volume is 78. Below 80. His erythrocyte count is 7 million. Hematocrit is 55%. Everything else, not too bad. Red cell distribution width is high. Alright, so which of the following analysis is most likely to be decreased in this patient? So you start looking at all your answer choices, and it makes sense that his erythropoietin should be low. He has so much blood, he doesn't need to make more erythropoietin. Why would he make more blood, This patient has polycythemia vera as evidenced by the erythrocytosis, granulocytosis, and headaches and dizziness. EPO is decreased due to the erythrocytosis. Decreased LAP would indicate CML, not PV. Right? The answer choice B, leukocyte alkaline phosphatase is actually high when you have a left shift, when you're making new neutrophils, new everything. And it's supposed to be high in a left shift, in the leukomoid reaction, because you're actually sick. But if you have CML, where you have high amounts of all your left shift stuff, that's actually a cancer. You're not fighting a reaction. So in those patients, LAP is low. So that's just me explaining the LAP significance. But for this question, it was really easy. You know this patient has super high amounts of blood, so his erythropoietin must be low. Unless it was his erythropoietin that was causing him to have a lot of the blood, but they didn't tell us that. That's not the scenario here. Right? He doesn't have any kind of cancer as far as we can see. 49. A 2-week-old male newborn is brought to the physician by his parents because of yellow skin for 7 days. The mother is extremely obese. At birth, the newborn has severely lethargic and hypoglycemic, and was fed both IV as well as orally with the soybean formula until the age of 4 days. He has been breastfed since then, but he has been vomiting most of his feedings. Physical exam shows jaundice. There is no glucoseuria, but reducing substances are detected in the urine. His serum direct bilirubin concentration is increased, and assay for which of the following would have most likely established the diagnosis in this patient at the age of 3 days. Okay, so he was given soybean formula, and now he's presenting with lethargy, vomiting, jaundice, right? A lot of things. It's not a fructose thing. Remember from biochemistry that the fructose things are pretty benign. So if we go back to that page 80, the fructose things are very benign. Essential fructoseuria, nothing happens at all because hexokinase takes over. In hereditary fructose intolerance, they just have a little bit of fructose intolerance. But, symptoms present following consumption of fruit. And what do they present with? Just symptoms of hypoglycemia, jaundice, cirrhosis, and vomiting. That's it. But our guy is actually lethargic and has many other things. Okay. They also found reducing substances, and what else did they tell you here? Yeah, so your answer choices here have fructose or fructokinase, and you definitely can't pick either one of those. Right, fructokinase just gets replaced by hexokinase, so that's okay. They didn't give the answer choice aldolase B. If they gave aldolase B, it would actually fit this question scenario too, because they didn't give you cataracts. If the question said that the baby had cataracts, it was guaranteed you would know that it's a galactose issue, because the galactose issues are the ones where you start getting cataracts. And the galactose issues, even in the less worse one, the galactokinase one, the benign condition, you actually have failure to track objects because you're going to get infantile cataracts. And then classic galactosemia is really bad. That one has the damage to the eyes, as well as the chance of having this E. coli thing, sepsis. Right? So you get infantile cataracts, intellectual disability, failure to thrive, all kinds of stuff. So you had to pick an answer choice that had to go with galactose, and you could just pick that, C. This is not a glucose 6-phosphatase deficiency, nor is it a glucuronyl transferase. Glucuronyl transferase would just be an issue with conjugating bilirubin. That's not what's wrong with the baby. This also is not lactose deficiency, so it's not, lactase. You're not going to check for lactase, and that's really all you have to do here. Last question, 50. Transmission of a bacterial agent by person-to-person contact is most likely to occur in which of the following infectious diseases? And you know that for meningococcal meningitis, you have to give all close contacts rifampin. Right? That's something that Sketchy Micro also teaches, and you just know that close contacts get it because we're talking about meningitis commonly being seen in close quarters, like college campuses and army, etc., etc. All right. Cholera, Legionnaires, Lyme disease, and Rocky Mountain spotted fever do not have person-to-person contact, at least not as commonly. Right? It's not really something that happens in that manner. So that's it for that. Tomorrow at noon, I'll continue on Block 3. Thanks a lot for joining. Hope all this is helping you guys. Keep studying, and I'll see you guys tomorrow.